welcome everybody. Hello and good afternoon. Welcome to this lunchtime lunch and learn about greener general practice and about improving asthma care in particular. My name's James Waldron. I'm a GP that works with a Nottinghamshire Alliance training hub and a portfolio GP and do lots of other bits and pieces around and run these CPD programs. We've got loads and loads of CPD on, this being one of them, but we've got other things coming up as well. And we've got a full day conference, a full day education coming up in May and in June as well, and loads of other evening events. Make sure you're plugged into that by going to our website, which Denise is going to put in the chat. Also, we have something called Grow Not Primary Care, which is our app, which you can download for all the workforce across Nottinghamshire to find out about CPD, events, funding, all of that kind of stuff. So please download that onto your phone, have a little look, try it out. It's completely free. And that's just a really nice way of just making sure you're up to date with all these bits and pieces. So a few things about today. We are recording today's event. You won't appear on the video itself unless you ask a question on the microphone and have your video on at the same time. So otherwise, don't worry about it. But I can see we've got some people joining us in person. It's really lovely to see faces. So if you do want to keep your camera on, that is absolutely great. And we really do encourage that. I will be, and then we can see people sort of following along. And it's really like we're all in the same room together. Other things about today, we're asking for questions and comments, so pop those in the chat. That is absolutely the place for it, so that we can ask questions to our expert. We might come to some of them at the end or as we go through, depending on what it is. Right, that was just a very quick one. Sorry for a little bit of a late start as we ironed out some of the technical gremlins out of the Zoom platform. You didn't come here to listen to me, so it gives me great pleasure to introduce you to Dr. Jess Hall, who's going to be talking to us about today's subject. It's a subject I know she's very passionate about, and so it's going to be an absolutely excellent talk. So enjoy. Thank you very much, Jess.
Good afternoon, everyone. I just first wanted to say really sorry for being slightly late. That was completely my fault, not James and Denise's. I was having some technical issues my end on my computer, so sorry to keep you all waiting. So my presentation today is about providing really high quality, low carbon asthma care. So I'm a GP. I work in Rushcliffe as a salaried GP and qualified in about 2015. I am kind of partway through a fellowship with the Phoenix program. So I've been doing it for about 18 months. And the focus of that fellowship is greener asthma care and sustainable healthcare. So that's kind of really what's brought me here today talking to you about this topic, which, as James mentioned, something I'm really interested in and really quite passionate about, actually. Through that work, I've become the respiratory lead for our primary care network. So that enables me to kind of really focus change within our primary care network. I've also helped set up a local greener practice group. And if you are interested in sustainable healthcare or working more greenly, then please come and join us, and please contact me if you want to. And lots of this presentation is based on slides and presentations from the greener practice group. I also kind of do a bit of work with the ICS at the Children and Young People's Asthma Group. So respiratory has become a bit of a focus for me in recent times. So what are we going to cover today? We're going to discuss the scale of the problem. So why is it important to think about greener asthma care, but also better asthma care, and why they're linked together? We'll talk about why inhaler prescribing is a carbon hotspot, especially within primary care. I then hopefully will introduce a bit of a framework to help you discuss green inhaler principles with your patients, introduce lots of resources and ways of talking about the topic. I'll also briefly chat about the Nottinghamshire Area Prescribing Committee asthma guidance, how that's changed and how it can support you to make greener changes. So just moving on to a bit of background, you might have seen these before. These are climate stripes. So these provide us with visual representation of the temperature on our planet. So as we can see, the world is warming. We know it is, we know it's happening. It's been in the news just this week about how and why we need to act. But furthermore, we know that climate change is inextricably linked to health. And we will already be witnessing and seeing the negative impacts of climate change on our patients within our day-to-day practice, whether that be extreme heat, air pollution, severe weather, flooding, those sorts of things. And what we need to do is try and feel empowered to be aware of these risks and how we can talk to patients about them to help them mitigate their risk of problems. This is really relevant to our patients with respiratory conditions and the impacts this can have on their health. So the impact on respiratory health can be subdivided into a few more categories. We've got air pollution. So air pollution is accountable for in excess of 28,000 deaths per year in the UK. So we know that air pollution can worsen asthma care and trigger fatal asthma attacks. Ella Adukisi-Deborah was a 9-year-old girl who lived in London near to the North Circular. And it was recognised that her severe asthma attacks were linked to when there was high air pollution days in her around her home. And she was the first person, when she died, sadly, when she was 9 years old, to have air pollution listed on her death certificate as a cause of death. Oops, sorry, went too quick. Pollen and mould, delightful topic, but because of rising temperatures, increasing atmospheric CO2, longer flowering seasons, there's an increase in bioallergens that are present in our atmosphere. And this, together with thunderstorms, increased rainfall, which increases the bioallergens in the atmosphere, can again trigger and worsen respiratory health. Extreme temperatures, now this can be extreme heat, which we know we've all seen in recent years. We've had record-breaking summers, record-breaking temperatures. And it's worrying to see, but also it can really have a severe impact on respiratory health. And we're seeing the most vulnerable in primary care, young children, the elderly, pregnant women. But it's also appropriate when we think about cold weather. So in the winter time, and especially with the cost of living crisis now, people are struggling to heat their homes, insulate their homes, and have appropriate home environments, and that can worsen respiratory health. We know there's an increase in zoonotic diseases associated with climate change. I can't see the one underneath there, but I know it says mental health. And so mental health, it also can worsen when we witness climate change and what natural disasters, or when we're worried about the climate, that can worsen our mental health, and that can have an effect on respiratory health and cause asthma attacks. So it all feels pretty bleak. It feels a bit hopeless, and it's hard to feel like, well, what can I do to make a change? How can I have any impact? But it's actually a really good opportunity to start to use these facts and figures and think, oh, we can act. And actually practicing sustainably and practicing with the environment in mind is typically in line with just good medical care. So it gives us the opportunity to really think about the way we're managing our patients, especially with asthma, because green asthma care is typically aligned with good asthma care. And we'll talk about why it's important that we're thinking about asthma outcomes in this country as well. So why is the NHS important? Why do we need to start thinking about this? Well, the NHS itself is a really big emitter. So it's responsible for 3% of overall greenhouse gas emissions in the UK. And so you can see here that's the equivalent of all the planes taking off from Heathrow in a given year. So we're a big emitter, we're part of the problem. And this infographic here talks about the emissions and breaks that down from the NHS. But what I just want to focus on for this talk is inhalers. And inhalers are a real hotspot for emissions within the NHS. And as such, lots of green plans and the NHS net zero plan really focuses in on inhaler prescribing, because it's an area where we can really make a difference. And inhalers account for 3% of the total NHS greenhouse gas emissions. This is really relevant and becomes really important within primary care because we prescribe lots of inhalers, all right? And our carbon footprint in primary care is really attributable to the prescriptions we issue and pharmaceuticals. So this infographic here, you can see the infographic itself is slightly old now, but it's still really appropriate to current time. And the important thing to look at is the orange bars. So the orange bars are carbon hotspots within primary care. And all we need to know from this is the tall orange bar in the middle is pharmaceuticals and GP prescriptions. And 25% GP prescriptions account for 25% of our GP carbon footprint. So what this means is we know that inhalers account for a huge amount of the NHS greenhouse gas emissions, and we know it's really important within primary care. So why is it an issue? What's the problem with inhalers? Well, this is down to the type of inhaler we prescribe and how many we prescribe of it. And this is typically down to pressurized metered dose inhalers, or PMDIs. So they're the inhaler that you can see on the top of the infographic here. I think the one that we all associate with asthma, actually, because that's typically what people have been prescribing over the last 10 to 20 years. And what they have in them is a propellant. And the propellant is used to help expel the medicine from the little canister when you press it down into the patient's lungs and distribute it. And it's not the medicine that's the problem, it's the propellant. So these HFA propellants are potent greenhouse gases, up to 3,000 times more potent than carbon dioxide. And there are alternatives. So we have dry powder inhalers and soft mist inhalers, which act in different ways, but deliver the same medicines into the lungs of patients with a much lesser carbon footprint. And so we can see from this infographic here, which is from the website Green Inhaler, the top inhaler is a Ventolin Evohaler. And if we learn nothing from this, is that we need to try really hard not to prescribe that, because the carbon footprint of a Ventolin Evohaler, which is an MDI delivering salbutamol, is equivalent to the tailpipe emissions of 175 miles. So that's the equivalent of traveling from Sheffield to London. A dry powder inhaler that's the same medicine, but just a different type of device, so a Ventolin Accuhaler, has the tailpipe emissions equivalent of 4 miles. So we can see already that we've got a clear, huge difference between the carbon footprint attributable to both of those inhalers. And we could prescribe differently, perhaps, to reduce our carbon footprint. And we prescribe very culturally in the UK. We prescribe loads of metered dose inhalers, and most of those are short-acting beta agonists, which is a problem in itself. And this is in stark contrast to many European countries. So for example, in Sweden, their proportion of metered dose inhalers is 13%, and their asthma outcomes are no worse than ours. So we know now we're being encouraged to think about things differently and consider the climate in the way we practice. And this is being brought in by NHS Net Zero, which is encouraging us within the NHS, the target of being net zero for carbon by the emissions we control directly by 2040, and indirectly so via the supply chain and such like by 2045. And within our integrated care system, we have a green plan that has been put together by a team of specialists to help us reach that target within the integrated care system. And like we said, inhalers have been a real focus. So now moving on to a little bit about asthma outcomes and why actually we need to work to better asthma outcomes within the UK. The UK has one of the worst mortality rates related to asthma in Europe. And in the last 10 years, our asthma-related deaths have increased by 26%. NRAD has stated that in 2014, 2/3 of asthma deaths, however, are preventable. But we know, according to the Asthma UK survey in 2021, which is the graph on the right of your screen, that only 30% of our patients with asthma are receiving basic care. So that's an annual asthma review, a personalised asthma action plan, an inhaler check. So that leaves 3.8 million sufferers of asthma in the UK without basic care. So really here, again, I think we can see this as a golden opportunity. We know asthma outcomes in the UK and asthma care could be better. And we know that we're in a climate disaster essentially at the moment, but we can together really look at how and what we're prescribing for asthma to improve our asthma care, but also reduce our carbon footprint. So really it's a win-win situation. I think sometimes people worry about patients. You know, are we going to put this to patients and they go, I don't really care about the environment. I don't want to talk about that. I don't want to change my inhaler. And we will get some, you know, some blocks, and that's fine. But actually, an Asthma UK survey at the European Respiratory Society last year surveyed 12,000 patients, so quite a large cohort. And they were asked, would you change your inhaler for environmental reasons? And 60% of patients said yes. 21% rather said maybe, and 19% said no. So actually, I think it's about us as clinicians and people that are patient facing being empowered to have these conversations, start the ball rolling, and get people to start thinking about it. And you might not, get everyone to change or everyone to start thinking about it, but we can really start to plant those seeds and move forward. So now moving on, I'd like to introduce some green inhaler principles that you can follow when managing your patients with asthma to try and optimize their care but reduce their environmental impact. And this is based on the Greener Practice Asthma Toolkit, which is really easy to digest and easy to interpret and on their website. So that's a really useful resource if you're interested and want to learn more. So the 4 main pillars are at the top here. So optimizing asthma care in line with national guidance, offering dry powder or soft mist inhalers first choice when appropriate for the patient in front of you. If we need to prescribe a pressurized metered dose inhaler, and we will for lots of our patients, choose a brand and regime to minimize your carbon footprint. And there are lots of ways of doing that as well. And also there's a focus on disposal and appropriate disposal of inhalers. So firstly, optimizing asthma care. So we know that the carbon footprint of poorly controlled asthma is 3 times that of well-controlled asthma. So actually, if we do nothing more than optimize the care of our patients, which is better for them, we will reduce our environmental impact. And this is the stuff we should be doing day to day. And I know I'm first to admit we are time pressured. It's really hard. We can't do it with every patient, but it's things like reviewing diagnosis. Does this person actually have asthma? Do they have another lung condition? Thinking about things like smoking cessation, vaccination, exercise, getting people outside, getting people active, improving their lung function. You can do that with things like singing groups and all that sort of thing. Social prescribing, another way of really improving adherence to treatment and empowering patients. But then that basic care element. So making sure we're checking inhaler technique and providing personalised asthma action plans. And lots of this will be our esteemed nursing colleagues who are doing lots of these things. But actually, when we're seeing patients with asthma, we can get GPs as well and AMPs and all that all that kind of allied healthcare professionals can really start to make sure we're touching on these bits and bobs as well. And there are lots of ways of checking inhaler technique. With the Right Breathe website and Asthma UK have lots of videos that you can share with patients or pop on when they're in your room. And the reason that's really important is because if a patient's taking an inhaler, but they're not using it efficiently or effectively, if the medicine's not getting into their lungs properly, it's not good for their control, but it's also not efficient and not very good for environmental impact because it's a complete waste of a drug. So that really kind of helps both elements. We do have an issue within the UK of short-acting beta agonist over-reliance. And so 70% of the inhalers we prescribe are short-acting beta agonists. And we know that actually this is not addressing the underlying airway inflammation in the condition itself. There's no doubt that short-acting beta agonist has a really key role in acute asthma and treating that immediate relief of bronchoconstriction. But we know that dependence and over-reliance as such is a risk factor for exacerbation and death. So our well-controlled asthmatics should only use between 1 and 2 short-acting beta agonist inhalers a year. And this accounts for actually 4 to 8 puffs a week. And when we think about, we've got patients that I see, day to day that are on 6 inhalers a year, 8 inhalers a year, sometimes over 10 and 12, they're getting so much short-acting beta agonist, which we know is not treating the underlying airway condition. So we have overuse of short-acting beta agonists, which we know then means that people don't use their controller medicines as appropriate, as much as they should be doing. We get increased exacerbations and, like we said, increased mortality rate associated, but we're not treating the underlying airway inflammation. And this can lead to fixed airflow limitation and remodeling. So I really like to talk to patients about building up your steroid armor, because actually this is something you need to be taking regularly over weeks, then months, to really build up that thick armor and reduce your risk of a chink and therefore an exacerbation. So it's really stressing to patients, the medicine that's going to treat your underlying airway disease is your preventer, not your reliever. So the goal really is to wean that dependence of SABA and think of it as an emergency medicine. So like we think of like GTN and hyperstop, that sort of thing. So not part of day-to-day management, you need it in an emergency when your control really deteriorates. So I think it's always important to be aware of what the guidelines say. A little dry, I know, so I'll try and summarize it very briefly. So the GINA guidance in 2021 has now made a step change to suggest that short-acting beta agonist monotherapy now is not recommended. And they've stated that not having inhaled corticosteroids is a risk factor for developing that fixed airflow limitation that we just talked about. So no longer recommending SABA alone. They recommend that every adult or adolescent above 12 with asthma should receive an ICS containing controller. And actually, their first line is PRN combination. So formoterol and ICS, preferred or regular daily ICS and PRN salbutamol. And so this just highlights that in a bit more detail. So you can see the preferred chain. So the preferred treatment regime is the top one there. And that uses a combination inhaler. So it removes that SABA altogether. And there is another option below where you have the PRN SABA, but it just really shows that there's been a step change in guidance. The NICE guidance is due to be updated this year in line with BTS, and it's likely that this will change. But NICE still continues to promote a role for SABA monotherapy for a small group of patients. And recommending that when your asthma is uncontrolled, so that typical, waking at night more than three times a week using a short-acting beta agonist, then you introduce a preventer inhaler. BTS and SIGN currently, again, says short-acting beta agonist for all patients, and again, step up like the NICE guidance, so very similar. Interestingly, our area prescribing committee guidance was updated last year, and that has been done. We're really starting to try and update the APC guidance in line with the green agenda. So the adult guidance was updated last year, and the children's guidance has gone through its final iteration, is due to be released over the coming months. And so there is a step change from that, saying a SABA alone should only be prescribed for a really limited number of patients with infrequent mild symptoms, so less than twice a month. So really now, if people are using a blue inhaler, they should be on a preventer. Just a quick word about MART. I've included a snapshot here from our APC guidance where you can find how to use MART and where it is in that guidance. So it's an add-on therapy here in the middle. So we've got a couple of different options. And MART is probably underused in this country. And I think it's hard to feel confident with it sometimes. But essentially, maintenance and reliever therapy means that you have a single inhaler that has an inhaled corticosteroid and a fast-acting, long-acting beta agonist, which typically is formoterol, for both relief and also maintenance. So you can increase your puffs throughout the day if you need to. And this is great because it simplifies therapy for patients because they only typically need to have the one inhaler mostly. But also, a lot of the inhalers we prescribe for MART are dry powder inhalers. So the good thing is often we've gone from the two inhalers, so maintenance and reliever, to one inhaler alone, and that's a dry powder. So that's better for the environment as well. And it can really help with the patient's control, because if they feel their symptoms are escalating, they can take more of their inhaler and hopefully prevent the need for things like oral corticosteroids and that sort of thing. So really try and get on control of exacerbations before they worsen. So I just wanted to have a little breather, just see if there are any questions before we move on now. I'm happy to move straight on if there aren't.
So yeah, we have one question that's come in. This: can MART be used pre-exercise? Thinking about the patients that might take a puff of the blue inhaler.
I can't see why not.
Yeah.
Because if you were going to take your blue inhaler before, there's no reason it couldn't be. There, I wouldn't have said. So I can think of any reason why not.
There's the question I had was, why do you think that the UK is so far behind Europe in terms of our use? Because I mean, it was quite astounding seeing that we are, triple the next closest person.
Yeah.
Is there? I assume there might be a cultural thing, or is there sort of medicines that we use?
I think a lot of it. So this is anecdotal from things I've, presentations I've been to, and what people have said, but I think it's probably to do with pharmaceutical companies. And so what we, I'm sitting in the greener inhalers group at the APC. They kind of detailed that over 20 years ago, we actually prescribed lots of dry powder within the UK. And then due to kind of pharmaceutical companies and what was pushed and what was, that sort of thing, not cheap and all that sort of thing, we started prescribing a lot more NDIs. And so it's just that kind of shift happened naturally. And I think, from my point of view, I must say that's what I used to just issue. I just used to issue metered dose inhalers all the time. And obviously I still do now, still issue some, but
hey, don't prescribe that.
Yeah, I just think we just use, that's how we were trained and all that sort of thing. And so I think the good thing now is it's becoming a real focus, and so that's changing what pharmaceutical companies are, their kind of plans as well, and they're being asked to think greener and develop they're developing less propellants with a lower environmental impact. So for metered dose inhalers, there are propellants in that are being made that will be better for the environment as well. So hopefully there's a real top change now, but I think it's to do with that sort of thing.
Brilliant. Okay. Another question has come through. Symbicort versus Foster with spacer. How does technique come into it? Yeah, no, I was actually thinking that myself. Like I think people are quite used to the, type movement.
Yeah.
Whereas trying to do that education around it's going to be a really important thing. How do we get patients on board?
So we'll do some. I'm just going to, when I move on, there's some bits and bobs on technique and device choice. I think so. I can answer that in a mo when we move on. The other thing I'd say is, are we saying Symbicort or Foster MDI or DPI? Because the MDI will be with a spacer. The DPI won't need a spacer, which is something we'll talk about. So actually, it's a lot better for patients because they don't have to have a spacer. I think lots of patients don't, but to improve delivery, MDIs should be given with a spacer, and so you don't then have to carry them around. But I'll move on to device choice now, if that's okay.
Yeah, that's it. I'm racking my brain to think of all those people that I've prescribed the alternate thing and be like, oh, and you don't forget your spacer, and they'll be like, how do these two things fit together?
Yeah. Cool. Right. So shall I move on and then we'll talk about device choice a little bit. The next stage in the Agrina inhaler principles are thinking about offering dry powder or soft mist inhalers first line where appropriate for that patient in front of us. So that's really key. We don't kind of just switch people without them knowing, or if it's not in their best interests. The best inhaler for the patient is the one that they'll use effectively and regularly. Okay, so then that will be better for their asthma control and better for the environment as well, but really that's what's best for the patient. So if we feel it's appropriate to issue a dry powder or soft mist inhaler first line, then we need to just go for it. And so this is again a snapshot from our formulary where the salbutamol entry has been changed in the last year, and now first line short-acting beta agonist on the NOTS APC formulary is a dry powder inhaler. So that's Easyhaler salbutamol. Second line is Salamol, and I'll talk about why that's come in second. And third line is Salamol Easy Breathe, which is a breath-actuated inhaler, which is often great for patients as well. So that's an MDI, but a breath-actuated one. And so you'll see from that, Ventolin is not there, and that's because Ventolin has a huge carbon footprint. Okay, so Salamol is now our kind of MDI of choice. This just shows that, again, bringing you back to that asthma guidance, because I use this all the time, so I thought it would be good to kind of bring it in, is that you do have options for DPIs for the other stages as well. So you've got Easyhaler beclometazone for your regular inhaled corticosteroid, and then you've got Foster and Fobumix that are dry powder options as well. So there are ones you can extricate from our APC guidance, because I think it's much easier if we have that support there and know where to look, rather than thinking we have to kind of figure out what we need to prescribe ourselves. I find it very useful. And so here's a little bit on device choice. So like I said, Asthma UK, Right Breathe have great videos for patients that you can sit with them. You can also use in-check devices as well. So a metered dose inhaler is a slow and steady inhalation over 3 to 5 seconds. And actually, it requires quite a lot of coordination. I've used both an MDI and a DPI. And MDIs are tricky, and lots of the medicine often goes around people's mouths, into their mouth, into the atmosphere, rather than actually into their lungs. So it either requires your breath actuation and coordination, like James mentioned, so pressing and breathing at the same time, or a spacer, or the easy breathe, so like an easy breathe Salamol. So it's good for people with poor respiratory flow. So that's people who are very old, very young, with severe or unstable disease. These are unlikely to have a dose counter. And so there's evidence to suggest, which I'll come on, I've got a little graph on this. Is it here? Yeah, here. So this was from a recycling, which is now a GSK recycling project, which isn't active anymore, unfortunately. But on average, around half of medicine remains in returned metered dose inhalers because they don't have a dose counter on. And so patients don't know when they're empty. It's really hard to tell when they're empty, like by shaking them or anything like that. And there are ways you can like see if they float and see how much they weigh, but people aren't realistically going to do that. And so actually people are chucking away inhalers that are half used, which is a waste, isn't it? It's clearly a waste, but also it's hard for patients to kind of have control of their asthma inhaler ordering as well in that regard, because you don't know when you're going to run out. That actually can be quite stressful and potentially lead to over ordering. So dry powder inhalers, they're good for pretty much anyone else. And so this is a quick and deep inhalation over 2 to 3 seconds. You don't need a spacer with a dry powder inhaler. And the really good thing is it's likely to have a dose counter. And so it has a little dial on the side of it. Every time you use one, it goes down, 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 down. And that's good for keeping an eye on your control. So you know how many puffs you're using each week or each month, but also feeling empowered to know when you need to reorder. So you know exactly where you are with it. So I've just been over that slide, so we'll click over here. If you need to use a PMDI, which you will for some patients, and it will be completely appropriate, there are ways of reducing your carbon footprint related to this. So there are things you can do to reduce the environmental impact. And so just bringing you back to that formulary entry from our APC for salbutamol, the reason it's been changed is if you look at this table on the right, a Ventolin Evohaler has a carbon footprint of the equivalent of 28 kilograms of carbon dioxide. But Salamol, which is it's about 5 up from it. So that's the same drug, same type of device, so a metered dose inhaler, same technique, has a carbon footprint of 11 kilograms of carbon dioxide equivalent. So with that one switch, you're over halving your carbon footprint. So there are real ways that you can reduce your carbon footprint just by changing the brand that you're prescribing. And so this just kind of shows that in more detail. You can see the carbon footprint attributable to the Ventolin Evohaler here is huge at 28. It also shows how bad Flutiform is. So Flutiform is very similar to Foster, and avoiding prescribing Flutiform if you can is really important because that contains a really nasty propellant. But it just shows that comparison there. And so that shows how important it is to prescribe by brand. We used to be encouraged to prescribe generically, and actually now we're being encouraged to prescribe by brand because the chemist will dispense what they have in stock, and typically historically that will have been Ventolin, and we have evidence to suggest that between 70 and 80% will be dispensed as Ventolin. We actually in Rushcliffe have just done a bulk switch of 7,000 patients from generic salbutamol and Ventolin to Salamol with patient information and a text, because it's the same dose, like we said, same device. And actually that's been really well received, and we've had hardly anyone wanting to switch back. So consider an inhaler with a dose counter, really important, but also think about the number of inhalers we're prescribing per year. So if you're on Clenil, for example, the maximum inhalers you're going to need if you're on 2 puffs twice a day is 8. So when you're prescribing this, maybe discuss with your patients, oh, actually, can I set your max issues at 8? Because what I don't want is the pharmacy to order you 12 when you actually only use 8, because that's a waste, and you'll just, it's completely not in anyone's interest. Avoid Ventolin Evohaler if possible. There will be patients And we have them in our surgery that say that's the only one that works, that's the one they want, and that's absolutely fine. If patients feel they want that inhaler, then brilliant. But if we're starting new issues and talking to patients about it, it's important to try and avoid that if we can, just because of the carbon footprint assigned to it. If you go to prescribe generic salbutamol or Ventolin now, when you're on System 1, so I'm a System 1 practice, I'm afraid, rather than EMIS, you will get one of those messages come up from the APC telling you, please don't prescribe this, please consider Salamol, or please consider a dry powder inhaler because of your environmental impact. So there is that prompt there now for us to help us in our day-to-day prescribing. And like I said, avoiding Flutiform and Symbicort MDIs, because they contain an even nastier propellant. The other thing I say to patients is when you're thinking about, this is for stable patients, so people who are stable on maintenance therapy, if they're on 2 puffs of 100 mics of Clenil and they're nice and stable, reduce them to 1 puff of 200 mics, because their inhaler is going to last twice as long. They're going to pay half as many prescription charges. You don't need to take as many doses each day. So you're going from 2 twice a day to 1 twice a day, and you're going to halve your carbon footprint. So again, a simple way of reducing your carbon footprint. Just a little word about cost. The good thing is the APC will have thought about this for you. So if you prescribe in line with the APC, you don't need to think about it. But for those who like to think about cost, there's a lovely press quip document that details switches with a cost saving, cost neutral, and with a cost, so green, amber, and red. And Ventolin Salamol saves you 4 pence, so that's great. So that's positive. And Foster, if you switch from Foster PMDI to Foster Next, that's cost neutral. So they're simple ones that we might do every day that we know aren't going to have a cost implication for our practice or our PCM. I think I'd also really encourage you to think about value. The top shows the inhaled corticosteroids we prescribe on our formulary, and they're really comparable. So that's absolutely fine. And like I said, you don't have to worry if you're prescribing in line with our formulary. But thinking about value is really important. So not just absolute cost of an inhaler, because if it's an inhaler that's a bit more expensive, but the patient's going to take it, their control's going to be better, then actually their risk of exacerbation is lower, so you're not really seeing them as much. An appointment with a GP or an admission to hospital is really carbon intensive. So actually, if you can prevent that with a slightly pricier inhaler, overall, your value is going to be higher. We also have something called the Impact and Investment Fund, which has encouraged us to think differently about prescribing within PCNs, and so you can get an income stream via that. So just coming back to the 4 pillars. So we've covered the top 3. The 4th one is about appropriate disposal. So I never knew this until I did the fellowship, but inhalers shouldn't be chucked in household wastes, and they are. Everyone chucks them away in bins. They need to be returned to community pharmacy. The reason why is if you chuck them away in the bin, they continue to leak that nasty, horrible propellant into the atmosphere for years and years and years and years. So aside from just the plastic, the propellant leaking has a climate impact. Community pharmacies are, it's within their contract to dispose of inhalers appropriately via incineration. And that the incineration firmly degrades the HFAs into far less potent greenhouse gases. Now, there have been some pilots for inhaler recycling. There was one in Leicester, which is now closed. In Wales, one's just been set up. But inhaler recycling isn't something that's available to us in Nottingham at the moment, or nationally, really. That is the ideal, but actually at the moment, the best thing we can do is encourage patients to return it. And so there are a couple of resources you can use on the Greener Practice website. Is the one on the right that you can just stick up in your waiting room. In Rushcliffe, we put together an inhaler disposal poster, and we bulk text everyone who had one on repeat with that attached to ask them to return them to community pharmacy. So that's another way of accessing your patients, and just whacking them up in practice on your waiting room boards in community pharmacy. In our dispensary, we've got just a box that says used inhalers here just outside the dispensary. So it's, that they're in control of it, and they bring it in every day, but patients can just chuck them in there, and then they'll be appropriately disposed of. So when should we be discussing this? Whenever, really. When people present to you the first time, I think this is the ideal, and I find this easiest as a GP, So when I'm starting someone on an inhaler, whether a child or an adult, I find it easiest to have these discussions right at the beginning, because you can really kind of influence behaviour. And then it's working in conjunction with our colleagues, our PCN pharmacists do a lot of this within Rushcliffe. They chat to patients about kind of the device and that sort of thing. So medication reviews, annual asthma reviews with our nursing colleagues, but also when someone's been into hospital, by rights, they should be having a review. And I'm not sure this happens in lots of places, but, you know, after they've come out of hospital. And so that's also a really good time to talk about this. But it's about being joined up in our thinking. So if we're all starting to think about it, then we're all having similar conversations, which is really helpful. And then it's about how you approach it. We've talked about feeling empowered to have these conversations, but I do get it is tricky, especially if you don't feel you know that much about it. On the Greener Practice website, there's a video that you can send out to patients, and there's this one here on education and resources, which is a 9-minute video about how to talk about this with patients. So it's worth a watch if you want to. There are things to consider. Say, for example, if you're popping someone on Salamol who's been on Ventolin, it'll feel slightly different. So same drug, same device, like we said, but the reason it's got over half the carbon less than half the carbon footprint is because the propellant volume is less. So it feels slightly different. It might feel like less medication, but it isn't. So it's just about, you know, having these discussions before. And on the Greener Practice website, there are specific, and on the APC website, there are specific leaflets about Salamol that you can give to patients about why it might feel slightly different, but also why it's great. It's about being patient-centered and patient-focused. So like we said, the right inhaler for the patient in front of you. And doing that with we said lots of these patient resources. So there's actually lots available now on the APC website in line with green prescribing and the green agenda. And like we said, patient choice and your clinical judgment remain crucial. So it's working within that framework. These are two examples of, I think, really good patient-facing information from Asthma UK. And this is on an NHS Futures asthma toolkit, which you can access if you sign up to NHS Futures. But these are, I just think, really good patient-facing information. And I love a QR code, getting you straight to information. So there are lots of resources out there targeted at patients discussing the green agenda now and the environmental impact of prescribing. Finally, I won't go through this, but if it's on the slides, if people find it useful. This is a Greener Practice flowchart about how to discuss it, which I think is great. And it's a flowchart you can follow to really discuss this with patients. And I won't read through it because of time, obviously, not probably a bit boring, but it's there if you want to have a little look at it. So today, what I hope we've covered is a framework, starting to introduce a framework for providing really high quality but low carbon asthma care. And I'd really encourage you to start to bring climate into the consultation. So start to talk about it with some of your patients, you know, some of the time. And this isn't just related to asthma, this is all of our patients. And there's lots more to be learned about sustainable healthcare, but there's lots of things we can be talking about, and doing that with our patients is really positive. So feel empowered to discuss greener options with our patients, but also accept imperfection. So, you know, I'm a GP, I'm salaried, it's really busy. It can feel really overwhelming. And how am I going to do this as well? How am I going to, you know, impact climate change whilst just trying to keep my head above water? But actually lots of it is just good medicine, you know, talking about greener prescribing, deprescribing, thinking about inhalers. It's things we do anyway, but just doing more of it and accepting that we won't do it with everyone, but bringing climate into those consultations is really important. So these are some resources that you know, will be available on the slides, but really there's lots of stuff everywhere, but there are a couple of the areas I look to. So any questions? Sorry, I was aware of time, so I sped through things.
Brilliant. Well, we've got plenty of time for questions. So now is the chance, everybody at home, to pop them in the chat. We've got a couple come through. But thank you so much. That was really, really interesting. And then there's lots of great take-home points that we can use there to start having those conversations. So we've got let's have a look here. So in the past, there's been such a push to use spacers to improve technique and how effective the inhaler is. So are we moving away from that? Is there similar efficacy to, you know, inhaler plus spacer is to dry powder? Because you know, we talk to patients about, you know, maximizing the volume and it traveling further.
Yeah, I think so. With a metered dose inhaler, a spacer is optimal. So unless you're using an easy breathe, you're really going to improve the delivery of the drug into the lungs by using a spacer. We talked, so that's versus DPI. So dry powder inhalers, you don't need a spacer to improve the delivery. But with spacers, it's about being realistic, isn't it, as well? Because if you have a chat with a patient and they're not likely to take a spacer out and their technique's rubbish with an MDI, and saying to them, well, maybe should we consider a different one if realistically you're never going to take that spacer out with you. The other thing is, if you, on the Right Breathe website, you can put in the inhaler that you're prescribing, and it'll give you all the spacers that you can prescribe that are compatible. And some of them are littler, they're small. And so you can be like, I'm going to prescribe you a little one rather than a huge chamber. The thing I'd say is guidance wise, so in BTS and SIGN and all that shebang, for acute asthma, MDI and spacer is what's advised. So that is, you know, we are still being encouraged to kind of use a spacer for the delivery in acute exacerbation. So I think the answer is, yeah, you are still being encouraged to use spacers for MDIs. I still do, especially children. You know, I think it's really hard for kids to use inhalers. And so I make sure that a kid's got one at home, one at school. And so I do tend to prescribe them. I have a chat with patients about how to use them, and I do tend to prescribe them with MDIs, but with a DPI, you don't need to. So that's a positive of that.
Brilliant, thank you. Got another comment here. Many patients are saying their Salamol doesn't work. The Salamol doesn't work, MDI doesn't work. Has anybody heard the same thing or understand what might be causing this and kind of difference of things?
So I suspect, so we ran the numbers on that. So we switched 7,000 and we've had like less than 200 after switch back. So it's gone quite well so far, touch wood, in Rushcliffe. But some people do. We had a letter from someone about how awful it was. And I think it's to do with the propellant volume. So like we said, and like I said in the presentation, and it's, so the propellant volume is less with Salamol compared with Ventolin, and that's why it's got a lesser carbon footprint attached to it. But it's in that volume that is delivered, you're getting the same amount of drug, and it's the same technique. And so, especially if you're using a spacer, there's going to be no difference because you're just delivering the medicine in the same way. But it just tastes different. It feels different because there's less volume. So patients think, oh gosh, it's not working because it doesn't feel the same in the way it's delivered. But what the leaflets do is prepare. And what we did on the bulk text is we said, it was just a couple of lines that we said, your inhaler is being switched to Salamol to reduce its environmental impact. And it's in line with the APC, and lots of places are doing that nationally. And we said it may feel and taste different. See this leaflet to why that is. And so actually, I think it's just making sure patients know beforehand, it will feel slightly different. And this is the reason why, and it doesn't affect the amount of medicine that's being delivered to your lungs or how it's delivered.
Because I think a lot of people here, we're switching you and they go, oh, the cheaper one, isn't it? And actually,
cheaper one, absolutely.
Saving money, you're giving me the half good stuff. Was actually having that conversation, anticipating what they might want to know, I think is a big part of the battle. Same with a lot of issues, isn't it? In fact, you mentioned these leaflets and you showed some really lovely posters and infographics there. How do we get a hold of them? Because I looked at that and like I want to put that up in my surgery. How do we get a hold of them?
So the Greener Practice website is the first place I'd go. I'm like a cheerleader, but that is really good. So there's an asthma toolkit. There's an asthma toolkit which has patient resources on. Nottingham and Nottinghamshire ICS has taken some of those leaflets and rebranded them with Nottinghamshire logos and updates and things, and they're available via the APC website. So the way I find it on the APC website is if you go on the formulary, so not on the guidance section, but if you go on the formulary, type in salbutamol, there's a whole load of resources under the salbutamol entry that are like, talks about the environment and salbutamol prescribing. And there's another guideline on salbutamol and its environmental impact. So there's lots of them there. So they're the main places I'd find them. And if if you can, in our Rushcliffe PCN also has a website called Rushcliffe Health, and we've put a green inhalers zone on our PCN website that has some the kind of posters and things up there. So there are lots of places you can go. Asthma UK will have some as well, but where I go default is the Greener Practice Asthma Toolkit.
Yeah, that's good. I was having a little look before this talk, and there's lots of stuff there, and lots of ideas and videos and resources that we
really
nice
and there's stuff to be learned about lots of other topics as well. So not asthma's a real hotspot in primary care, but also there's so many other things we can be doing and learning about, and within how we practice and kind of how we deliver our healthcare, and that you can access on that website as like a bit of a one-stop shop.
Brilliant. Excellent. Well, I'll certainly be having a little look at that, and hopefully people at home will. I will pop that into the chat. It's been an absolute pleasure, Jess.
That's no problem.
I really feel privileged to have you come and speak to us, because your passion and enthusiasm, this really comes through, and I think that there's certainly really easy things that we can make changes within our practice. So thank you very much. It would be really nice to do some more of these in the future, and perhaps we can do like a bit of a study day or something like that to try and solve some problems altogether.
Thank you for having me. It's lovely. I love kind of chatting about this sort of thing. So nice to see everyone.
Oh, brilliant. So for everybody at home, I hope you really enjoyed it. I hope you found it useful. And there is a SurveyMonkey link. Please do not leave here without clicking that link and filling in that form. It's really, really helpful for us. It's helpful for our speakers for their portfolios, for teaching. It's helpful for us to bring you more stuff that we're going, more stuff and more education and more CPD that is really useful for you. So yes, we've made it by 2 o'clock. Thank you again, Jess. Thank you everybody for coming. Hope you have a lovely rest of your day, and we'll see you again at an event really soon.
Bye.
Thank you. Bye-bye.